of Dr. Mark Cohen and myself, Dr. Norman Galis, welcome to Rheumatology Practice in the Post-Biologic Era. As the title of this seminar implies, rheumatology has undergone tremendous and exciting changes in the last 5 years. We hope that the next hour will help you embrace these changes from a diagnostic, therapeutic, and practice management perspective as our chosen specialty continues to evolve.
I'm really excited to be here today to talk about new diagnostic methods and treatment choices in the rheumatic diseases. This represents a list of some of the topics I'd like to cover today and includes innovative targets as well as issues regarding the timing for therapy in our patients with rheumatoid arthritis. All of this is based on newer understandings of the immunopathogenesis of rheumatoid arthritis, and this slide really shows multiple targets and potential targets which we might try to get at as we try to treat patients with rheumatoid arthritis. All of these interactions clearly result in the kind of damage that we've seen over the years in our patients with these diseases. Now, I am as big a fan as anyone of the many therapeutic advances that we've seen over the last 5 to 7 years in the treatment of rheumatoid arthritis. These represent alternative dosing strategies, the ramping up of methotrexate, novel therapeutics, the use of drugs like anti-TNFs, and combination therapies, the combination of methotrexate and anti-TNF. But despite these advantages and advances, clearly some patients fail to achieve a substantial clinical response, and clearly most of our patients, unfortunately, do not achieve remission. In addition, therapy must be ongoing. There's no cure or long-lasting response, and previous joint damage does not heal. I think it's wonderful that remission has become a goal for therapy, but there is a need for novel strategy to treat rheumatoid arthritis patients who have not responded to some of these newer drugs. This represents an example of that. If this is the Swedish registry, one of the Swedish registries looking at patients with rheumatoid arthritis, and although there's a lot of information on the slide, concentrate on the last bullet. Only 40% of patients are maintained on anti-TNF therapy after 5 years in this registry. In this cohort of patients, there's something about those responses. They're either inadequate, there's something to do about the finances, there's something to do perhaps with toxicity that really creates the situation where the patients are not staying on the drug. Now, we know this, and all of our studies with these new drugs really require this kind of careful measurement of disease activity. This is an area, particularly in the United States, it seems to me, where we really do not frequently and consistently measure objectively patient responses. Now, if we have all these effective strategies, and we know that not every patient responds, it's incumbent on us, it's a requirement, it seems to me, to be able to measure which patients are responding and to what degree, and which patients are not. Even patients who go into a clinical remission still may have radiographic progression. There's this justification for the use of these expensive medications. There's the need to maximize the risk-benefit ratio in these patients. And I'm also concerned that third-party payers are not just going to be asking for these kinds of measurements, but are going to require it. In addition, I think one of the other areas that we have come to recognize is the early recognition of our patients with rheumatoid arthritis. And this, it seems to me, is also evolving. We now know that these newer therapies can suppress radiographic progression. But how are we going to demonstrate that? The use of newer technologies, MR, ultrasound, really have enabled us to identify synovitis and, to a lesser degree, bony change in a much more sensitive and perhaps specific way than plain radiographs and the traditional ways that we follow patients' disease. This, it seems to me, is one of the challenges for the future, and we'll talk about that a little bit later as well. The other sort of new concept that I want to get to before we talk about specific drugs is the concept of tight control. Look at the Takora study, which, as you know, was published in 2004, but to me really represents an example of what disease assessment, careful disease assessment, and the tying of treatment to that disease assessment permits. In this study, there was an intensive group, not with regards to intensive therapy so much as in intensive measurement, with the obligation that the physician increase the treatment based on the measurement if the patient did not go into remission. This was contrasted with a routine care group where the patients were reviewed every 3 months and the treatments were not necessarily tied to what the physician saw. The differences were obvious if you look at ACR 20 and 70 scoring as we have on this slide, or look at remission. Clearly, the intensive group responds much more dramatically than the routine care group. And this also extended, very interestingly, to radiographic progression, where the patients in the intensive group had much less, half as much radiographic progression. It's also interesting to note that this is a pre-biologic study, and even the patients with intensive measurement and therapy did have some degree of radiographic progression. Another thing I think we've learned and would agree upon now is that not just early treatment is important, but early combination treatment is important. This is the infliximab plus methotrexate trial termed ASPIRE, which clearly identified that the combination of this particular anti-TNF, infliximab plus methotrexate, was better than methotrexate alone in every parameter measured, from clinical response to functional response to radiographic response. And really it is these drugs, this example, I think, really tells us how powerful and what a different group of drugs this can be. Look at the suppression of radiographic activity, and in fact, in a subset analysis, and I'm only so confident to a certain degree about subset analyses, look at the observation that even those patients who did not achieve a clinical response still had significant suppression of radiographic disease. Fascinating, and this really represents one of the high new concepts that the anti-TNF drugs have provided us. Another fascinating thought comes out of the so-called BEST trial, a complicated trial comparing different kinds of combinations of drugs. But I'd like to look at the last group of patients, those patients who received infliximab plus methotrexate right at the beginning of their treatment course. And in this group of patients, it was possible, and in fact, 52% of patients, after achieving a clinical remission and radiographic suppression, were able to discontinue their infliximab for a while and still maintain clinical response. Now, some of those patients are going to go on to require probably retreatment later, but it's a fascinating thought that we might be able to intermittently treat our patients. And here is an example of that with the anti-TNF drug infliximab. One of the other anti-TNF drugs has also been studied in early disease in combination. This is the trial that compared methotrexate alone to adalimumab alone to the combination. And again, all endpoints, all clinical endpoints were achieved. The combination was clearly better than either drug alone in each and every one of these, from remission to function to radiographic suppression. And in fact, interestingly here, a subset analysis of this trial demonstrated that there was radiographic progression even in those patients who on methotrexate who had achieved a clinical response. That in fact, for any level of clinical response, in this slide, ACR 70 responders to both methotrexate and the anti-TNF drug, still the methotrexate group had much more radiographic progression than the combination group. One of the other things we've learned about treating patients with rheumatoid arthritis with anti-TNF drugs is that patients who do not necessarily respond to treatment with one of them can be switched to another. This slide demonstrates patients who did not have a particularly dramatic response to etanercept could be switched to treatment with infliximab and achieve a significant response. And there are other studies looking at switching in other directions. Not just switching, but the ability to change dose and dose schedules also are considerations with which rheumatologists are really comfortable. We've been doing this for a while. We need to remember these lessons as we think about the anti-TNF drugs, really before we change drugs. Infliximab may be the perfect example of a drug that allows all kinds of variability in dose and schedule, and we should probably remember that example and think about these aspects of these drugs before we consider changing to other alternative agents. Clearly, failure with one of these drugs does not predict failure to all, and I think we will see more and more information that allows us to know when to switch and maybe in which order to switch. So I think that this whole area of anti-TNF drugs in combination with methotrexate has made a tremendous impact on, not just on patients and their disease, but the way we really approach it. Well, one of the newer treatment targets out there would be co-stimulatory molecule blockade. This does not get at the first signal between an antigen-presenting cell and a T lymphocyte, but rather the second set of signals, the amplification set of signals, rather than the initiation signal. And this drug, this compound abatacept, was initially studied in patients with an incomplete response to methotrexate, the sort of typical group of patients, and it did demonstrate efficacy. Here you see ACR scores as well as DAS remission scores, and clearly the drug with methotrexate is better than placebo plus methotrexate. It also has the potential for some radiographic progression. Using these probability plots, you see that it's actually a small number of patients driving all of these improved radiographic scores, and it will be interesting to see whether this compound does compare favorably over the long run to what we've accomplished with our anti-TNF drugs. The other place I think these new drugs are going to be used is in our patients who have not had a dramatic response to our anti-TNF drugs. We've established that that occurs. Here's a study looking at abatacept in that group of patients who had really not achieved good responses to anti-TNF drugs. Here are the ACR 20, 50, and 70 responses. So this drug may have a place in patients who have not responded. Similarly, the B-cell therapies, I'm going to mention rituximab, another group of drugs really looking at a different, not just different target, but almost a different science. Look at all the proteins on the surfaces of B cells that might be potential targets. I think it's interesting in this slide, but the other key point of this slide is the different compartments in which B cells travel. The bone marrow B cells may or may not wind up to be in the periphery. Those B cells in germinal centers may or may not wind up in the periphery, and clearly the therapies that we have to date are really acting on peripheral B cells. So rituximab was studied in patients with bad rheumatoid arthritis, initially in patients who had failed methotrexate, using a protocol that came out of the successes of rituximab and lymphoma. Those protocols had a lot of corticosteroids. The DANCER trial here really looked at whether or not glucocorticoids were influencing efficacy, and the results were quite clear. Here down at the bottom, if you would, the effect of glucocorticoids on the ACR responses was nil, that in fact the glucocorticoids were not necessary to improve responses. The drug seemed to work. Look at the ACR 20 and 50-70 scores. Look at the changes in HAQ scores. And then in a different trial, this drug was used again in patients who did not have a satisfactory response to anti-TNF drugs, the anti-TNF partial responders or failures, or those patients who are intolerant. And this is where this drug is going to be niched, here demonstrating that rituximab plus methotrexate in this very difficult group of patients had allowed for the achievement of significant ACR 20, 50, and 70 responses that really, it again improved all aspects of clinical disease activity. And in fact, this drug also was studied with regards to potential radiographic effect. And this is the early data here at 6 months. It wasn't powered to show differences at 6 months, so this is early data. We're awaiting late data, but even this would suggest at least the potential that B-cell therapy may also achieve some radiographic response, and this needs also to be compared to what we've seen previously with our anti-TNF drugs. Are we going to be able to consistently retreat patients with rheumatoid arthritis with these drugs? I would remind you that almost all patients who receive these compounds do deplete their B cells. Is it going to be safe to retreat patients? Are we going to continue to get responses like we've seen with a single course of therapy? Well, I think this needs to be studied probably a little bit more specifically, but here's some very early information in an open label trial that a second course of therapy really achieved the same kind of efficacy with the same kind of safety that the first infusion set achieved. And I think it's going to be a very interesting thing to look at. Not only that, but this is an area that fascinates me, and that is whether or not the B cells that regenerate after they're depleted are going to be the same. a busy slide, but the question is, at repopulation, are we going to have a different type of B cell appear? And is that going to really not perseverate the disease? By repopulating with a different population of B cells, are we going to be able to get rid of disease ultimately? A fascinating question to consider, but one that requires further therapy. And there are other cytokine targets. We've been talking about some cellular targets. Let's think about the target IL-6. This is a pleiotropic cytokine. It has multiple effects, effects on the liver, effects on endothelial cells, effects on monocytes and macrophages. And this cytokine has been blocked with a receptor antagonist. So here is a study of an anti-IL-6 receptor antagonist compound that did achieve clinical responses quite similar to those we've seen with other cytokine inhibitors, fairly impressive. But because of the multiplicity of effects of IL-6, it'll be interesting to see whether blocking it is going to be safe. There were some early issues regarding lipids and liver function tests. So an interesting consideration. A drug that has already been used in phase 3 clinical trials, and we're really awaiting some of the more definitive trials to see whether this is going to be ready for prime time in the near future. Another cytokine that I think would be an interesting one to study, and there are some early studies looking at this, is IL-15. This is another cytokine that has a multiplicity of effects, but is really implicated as a key pro-inflammatory cytokine. This diagram sort of shows you some of the areas where IL-15 might be participating. Whether or not it's going to be interesting to block it, we've seen some early studies that it may be effective, and we await larger blinded trials, particularly phase 2B and 3 trials, looking at its effectiveness. Another set of targets that I think is very interesting and really different than the kind of things we've discussed previously is this sort of relationship between rank ligand, and OPG. Here it's clear from this kind of cartoon that rank and rank ligand have to do with the activation of osteoclasts and the activation of osteoclast activity leading to bone damage and erosion, maybe even osteoporosis. And it's clear that there's some balance of rank and rank ligand and OPG that is controlling physiologically what we see in our patients. And yet, this balance, you could imagine treatment opportunities that might change this balance, where an increase in rank ligand would be leading to osteoclast differentiation, activation, and erosion. You might be able to block that. OPG is a natural inhibitor, but what about increasing OPG, changing the direction of the balance? Some potentially fascinating areas that might not just be important for erosive rheumatologic disease, but think about potential impact on bone density, osteoporosis. And there are already compounds out there. Here's an example, AMG 162, of a fully human monoclonal antibody against rank ligand that specifically blocks this compound, interfering with that balance and hopefully interfering with erosion and improving bone density. Has implications for cancer, has implications for all kinds of inflammatory disease, as well as osteomalacia and osteoporosis. One of the other areas that I think is potentially very interesting is this concept of targeting small molecules. Remember the original cartoon, we've been talking about cells and cytokines. What about intracellular processes? And the potential to inhibit those processes is fascinating. Perhaps it would be even more efficient and effective. And this is a sort of a cartoon representing some of these intracellular areas where we might begin to interfere. And there is some early data, particularly in animal models. Here's an example of something that blocks this p38 kinase that participates in several intracellular areas. By blocking this, you really turn off adjuvant or induced rat arthritis. Now, going from the rat to a human is a huge jump, but it's a fascinating concept to think about, not just blocking things on the surface of cells, but interfering with some of the activity inside of cells. Whether it'll be safe, whether it'll be really important, of course, remains to be demonstrated, but it's a fascinating potential area, and I think you'll see a lot more work in the near future. And lastly, some comment about genetics in rheumatology. Now, this is not just gene mapping. This is not just trying to look at the difference between my genes and Norman's genes. This is about gene expression profiling. This is a dynamic interpretation of what genes do. This really marks disease progression and therapeutic response. This might allow for the subsetting of our patients. Who's going to have bad disease, who's going to respond to which drugs, and who's going to have toxicity from drugs. And this is very specific, complicated, sophisticated work, and some of it's already been published. This is a paper from ACR in 2004, which really looked at changing a single nucleotide, a single amino acid almost, looking at single nucleotide polymorphisms and how they might affect patients with early rheumatoid arthritis. This was actually from serum stored from patients in the ERA trial comparing etanercept to methotrexate, but that's really not the point here. The point was upper respiratory tract infections in response to therapy was associated with single nucleotide polymorphisms. A single change predicted toxicity. In one area, upper respiratory tract infection, a different nucleotide substitution was associated with urinary tract infections. So this is the beginning, it seems to me, of the ability to subset patients and think about all the areas where this might be relevant. Now, we have a long way to go here. These are very complicated, detailed kinds of systems, but I think you're going to see, well, we're already seeing more and more information, and I think ultimately this is the area where we're going to get those predictors in which we've been so interested. Now, in conclusion, let me submit to you that only a few of the approaches I've mentioned today are really going to prove both effective and safe. I believe that it's going to be combinations of existing and new therapeutic agents that ultimately are going to be the way we're going to treat our patients. And I'm also pretty confident that at least some of these approaches will also be effective in other systemic inflammatory diseases. We've already seen success in the spondyloarthropathies like ankylosing spondylitis, psoriatic arthritis, and systemic lupus. And I think it'll be very interesting to see which drugs are most effective in which diseases. And as I've just mentioned to you, I do believe that in the future, markers will be identified that allow us to subset our patients, not just with regards to response, but with regards to toxicity. And this is not just in response to a single drug, but to combinations of drugs. As I've mentioned, treatment with these agents will be applied earlier and earlier in the disease process, and I think there will be requirements for technology to help us measure very subtle changes in disease activity. I believe that patients will really need continuous or at least intermittent treatments with perhaps drug holidays in between, but that a single course of treatment is unlikely to provide a long-standing remission in our patients with chronic inflammatory conditions. And lastly, and probably most importantly, I really believe that long-term, careful studies are going to be necessary to fully establish the safety and the efficacy of any of these new therapeutic agents, and then the combination of these agents if we're going to more effectively treat patients with systemic inflammatory rheumatologic disease. Thanks very much.
Hard for me to believe I've been practicing rheumatology for nearly 27 years, and I can honestly say I'm having more fun, more gratification, and am much more excited than I ever have been in my career as a rheumatologist. When I look back and I see how the way we practice rheumatology has changed, it's actually mind-boggling. I think in particular in the last 5-7 years, the way rheumatology has suddenly emerged as this vital, exciting specialty that we have today. If we look where we were in the past, we were a specialty that consisted of largely cognitive services. We were, for the most part, academic, intellectual, and extremely unassertive. Most practices had a total lack of business expertise. There was no business plan, an overwhelming fear of debt. If you looked at most rheumatology practices, they were in the dingiest part of the building, the smallest, pokiest waiting rooms that the patients spend days trying to find. Overhead was minimal, and the staff usually consisted of a family member or someone who was the cheapest person that could be found. In addition to that, the CPT coding was a disaster. I mean, we were basically having unrealistic demands placed on us with regards to what was expected for our consultations. There was no recognition of repeat in-office consultative services. And in fact, reimbursement was losing to inflation. To this day, I'm getting less for a consultation with inflation than I got 25 years ago. If you look at the results of that, many rheumatologists kind of went into this mode where the smaller the better. The average exam rooms, and this is from a study done by the ACR that was published in approximately 2003, the average rheumatologist had 2.3 examining rooms per provider. You can't make a living that way, and you can't service your patient population that way. The average square foot per provider was 1,380 feet. And if you look at this study, there's actually a correlation between the number of exam rooms in a physician's office and their net income. Furthermore, there's a correlation between overhead rate and gross receipts. The more you spend, the more you generate, and the more you provide care for your patients. In fact, if you look at this benchmarking survey done by the American College of Rheumatology, it's very, very easy to understand the correlation that exists between ancillary services, square footage of office space, number of exam rooms, staff personnel, and ultimately income. So I think it's very important for us to understand that we need to expand our horizons when developing our practice. And that's why I'd like to spend a little time on the one-stop shopping department store approach. Not everything you see on that slide is for all of you. But what I'd like you to think about is the difficulty your patients have had going from one diagnostic service to one treatment service despite their pain and stiffness and discomfort when you order a blood test or an x-ray and they have to go somewhere else. And why would we do that? When we are the best ones to interpret our studies, we are the best ones to know what to do with our studies. The turnaround time when you do it in your own office is far superior than when you're sending it to a diagnostic center in somewhere far removed from your office. And ultimately, the ability to practice one-stop shopping as if you were going to a mall and being able to get all your needs taken care of in one trip is what your patients want. So physical therapy, lab, radiology, infusion therapy, clinical research, anti-aging, which may not suit your style of practice, but certainly are components that rheumatologists are incorporating to provide their patients with the type of services that their disease requires. One of the biggest complaints I hear from my fellow rheumatologists is how the day-to-day paperwork, the requirements for insurance reimbursement overwhelms them so that they don't have time to do what they do best, which is taking care of patients. Well, interestingly, in 2001, the ACR did a survey, and even then, 25% of all practices of rheumatologists in the United States were employing a nurse practitioner or a physician assistant. These individuals have the capabilities of really helping us out in diverse aspects such as history and physicals, taking calls, performing infusions and injections, and essentially acting as a complete facilitator for the rheumatologist's needs. I think this is a very, very good way to extend your own abilities to service your practice. Medicare accepts that. The Medicare reimbursement for nurse practitioners and physician assistants states that incident to reimbursement, services or supplies are furnished as an integral, although incidental, part of the physician's personal professional services in the course of diagnosis or treatment of an injury or illness. Which means that if they work together with you, you can bill under your own code. But be careful. In no way can a shared encounter be billed under your provider number if, in fact, all you're doing is saying you reviewed the nurse practitioner's notes and you concur. If that happens, the individual physician assistant or nurse practitioner may bill under their own code for approximately 85% of Medicare allowable, but not under your code. Overall, though, I think this is an excellent way to help you get through the daily operations in a much more cost-effective fashion. Some of you may be thinking of incorporating clinical research into your practice. I think it's a great idea, but not for everybody. But certainly the benefits, if you really do want to do it, are tremendous. The ability to offer patients state-of-the-art new medications, especially when they failed old medications, is obvious. the excitement and stimulation of a physician being on the frontier of new treatments in their specialty, in particular today in rheumatology where new treatments are just coming out the woodwork. I think if you're in a private practice like myself, it creates a semi-academic environment in which to practice. You're interacting with your colleagues both locally and nationally, and it gives you a sense of really being on the forefront of changes occurring in rheumatology. And then obviously there's income. And I think this is all part and parcel of developing your practice. But if in fact you are going to do it, there are no shortcuts. You need to have a certified clinical research coordinator to run the research side of your operation. I have never seen a physician who does day-to-day practice and clinical research equally. It's pretty much impossible. And I think if you are going to be serious about it, a clinical research coordinator is invaluable. Give yourself sufficient space and equipment. Once more, don't use that little broom closet for your clinical research. It won't work. You need storage space for your medications that are going to be separate from all your other storage facilities. You're going to need storage space for your records for 10 years. The ability to provide lab and x-ray services to support the studies is very attractive to the pharmaceutical companies when they're looking at your site and determining whether that'd be appropriate. So I think if this is something that you are inclined to do, go for it. I think it's a very, very exciting way to add to your practice. Infusion centers, I think, have become part and parcel of the modern day rheumatology practice. And when I say infusion centers, as you see on that slide, the infusion center is not the laundry closet once more. It's not the waiting room. It's not a corridor. And I recognize when we first started doing infusion therapy and when we started using infliximab, there was a question in many people's minds as to whether we should make the investment of an infusion center. I think there's no doubt any longer. Being a rheumatologist in 2006 requires that you do infusion therapy. So why not do it yourself? Get an appropriate center that would include the following: adequate space, an infusion chair. And as you see over there, the patients are sitting in infusion chairs. And if you were going to have an infusion for 4 hours, you would want to sit in a chair that was comfortable. The standard ancillaries, an IV pump, oxygen crash cart, obvious. Television set is optional. You may or may not want that because your patients may disagree on what they're watching. And staffing is very important. You need to have dedicated staff for your infusion therapy. But the benefits are supreme. If you look at the list of drugs there, we have infliximab #1. Now we have rituximab, abatacept, the other newer biologicals that are going to come out in the near future, the old standby solumeral cytoxan, IVIG, and even bisphosphonate therapy are going to be drugs that are going to be just part and parcel of what we're using. So if you want to be a rheumatologist, I think you need to really strongly consider having an infusion center and buffing it up. Other advantages: you're going to track clinical studies by having and clinical research studies by having an infusion center. You're going to become a referral center for other specialties that are starting to infuse but not in the volume that you do, such as dermatology and gastroenterology. And certainly the ability to personally supervise your patients who are having infusion therapy under your prescription is huge. I don't have to tell you how often patients who are referred to outside infusion centers run into problems because the individual administering the infusion is not comfortable or aware of the particular nuances and adverse events of the drug that you are using on a day-to-day basis. Without a doubt, if I'm going to be talking about practicing rheumatology in the post-biological era, MRI in rheumatology is here and growing and going to enhance the way we practice tremendously. That's my office up there, but I'd like to show you this picture, which I'm very proud of, because this was published in the Journal of Rheumatology a couple of years ago. And on the one side, you see a normal X-ray. I think you'll agree it's normal in a patient with rheumatoid arthritis. And yet, look at the MRI findings showing multiple erosions. I believe this has happened again and again and again. And I think the utilization of MRI in rheumatology is going to change the way we approach our patients in terms of when do we diagnose, when do we treat, and when do we change therapy. John Cruz published this article in 2004 in the Journal of Rheumatology, and like many others, using a small MRI, however, he showed that using a small MRI, we were able to identify more than twice as many erosions on the exact same patients with the same diagnosis at the same time. MRI is ultimately a beautiful tool for the diagnosis of rheumatoid arthritis because X-rays take so long to show pathology. And yet when you use the small magnet MRI, you're able to see thinner slices with thinner gaps or less gaps between each slice than conventional MRI. And I think that needs to be remembered. The actual small MRI, which has been validated and has a 95% specificity and sensitivity, shows more in the way of erosive disease than the larger magnets. It also shows bone marrow edema, which may be a precursor to the development of an erosion. So when you're looking at how you incorporate that into your practice in terms of choosing therapy, the clinical indications of MRI will be to diagnose the patient earlier, and then once diagnosed, to utilize the tool for monitoring treatment and adjusting treatment. And I think for the insurance companies, demonstrating successful treatment. In terms of the implication for practice, it's more sensitive than standard radiographs. It's sensitive to the patient's needs in which it's comfortable. The average test takes about 35 minutes per extremity. Most insurances, including Medicare, are paying for it. A positive MRI definitely expedites the insurance approval for biologics, and certainly it enhances your practices in terms of the latest technology and getting services reimbursed at reasonable rates. You need to have a standard size examining room for the small magnet MRI, a comfortable chair. Depending on which machine you're looking at, you may need to have a cooling system for the antennae. And the exam time, as I mentioned, is about 35 minutes for both a T1 and a STIR image. I believe that sending your images by DICOM format, which is the industry standard, to a radiologist is the way to go. I don't think it's practical for rheumatologists to be doing their own interpretation after a day of seeing many patients. I think the radiologist is more skilled in doing it. Having said that, that's up to each individual, and there are some individuals who are developing a very good expertise in measuring and interpreting their own MRIs. The ICD codes that are necessary for billing under rheumatology diagnoses are listed over there. Both rheumatoid arthritis, inflammatory polyarthropathies, and osteoarthrosis are recognized ICD-9 codes for the reimbursement of MRI. And I think if you look at the example of bone density, we've got a very similar example with MRI. The advent of bone density caused an explosion of early diagnosis of bone loss, which previously had been ignored. As a result of that, people were more aware of their bone loss. We had the development of therapies that without bone density would have not happened, such as the bisphosphonates. And I think if you use that paradigm and you put rheumatoid arthritis into the same context, the use of MRI is going to increase the ability to make an early diagnosis, increase in awareness for the physician and for the patient, and allow for an even greater trend towards the development of therapies and an understanding why therapies are necessary. So I believe that in the future, hand in glove with biologic therapy, in-office MRI technology is very important for the patient's well-being as we move forward. Just a few more parts of the practice that I do in my office, which once more you may or may not do. Having a clinical lab, there's benefits, there's risks. It's not for everybody. It certainly provides additional income, but not to the point where I think that should be the only reason you add it to your office. I think the benefits, fast turnaround time, SED rates done over there, ANAs, rheumatoid factors, CCPs can all be done in a very short time in the office. It allows you to have your own quality control, state-of-the-art, and once more provide something to the clinical research companies that are looking to utilize your site. But remember, it's labor intensive, there's a cost involved, clear certification, and most importantly of all, look at your payer mix. If your payer mix is too top-heavy in managed care, it may not be worthwhile doing your own lab tests. So I just point that out for you to understand that there is this option, depending on the type of complexity, for you to have your own clinical lab. I think by now most of you are very familiar with bone density, and I really don't want to spend too much time discussing what I think has become pretty standard for our practices, and rightfully so. You can't treat a patient for a rheumatological problem without being concerned about their bone status. But I would like to make one point. More recently, Medicare has actually allowed and approved for us to do a bone density after 1 year in certain situations. In particular, patients who are on prednisone 7.5 milligrams or more, individuals suffering from metabolic diseases such as thyroid or parathyroid imbalance, and certainly to help you follow the therapy that you've already started your patient on. Physical therapy and rehabilitation, very questionable at this point. The federal guidelines have limited the reimbursement per patient in a normal situation to approximately $1,760 a year. And I'm not sure whether this is not something you should step back and wait to see how the dust settles. Certainly the development of a cough or an ORF, which is something that takes a lot of time and expertise, may help expedite the ceiling. You certainly may be able to justify your patients needing more therapy, but I would be a little cautious. And as I said, this is something that's up in the air at the moment. And if you have an ongoing therapy setup, you understand. If you're about to embark on one, be very careful and cautious about which way you go. I put in this wellness anti-aging slide in not because I do it, and I'm not sure that we should be doing it, but there are practices of every specialty who are getting involved in the use of nutraceuticals, hormonal replacement therapy, acupuncture, chelation therapy, and so on and so forth. Depending on your bias, I mention it because it's out there. It's certainly not what I would call conventional practice of rheumatology, but I think it kind of opens our eyes up to the fact that we should be looking for more ways to provide our patients with what they want. Because as much as we want to dictate to our patients what they need, they also want to tell us what they want, and we need to be aware of their own particular requirements. I've always considered marketing an integral part of my practice, and I've listed there a number of areas in which there's marketing freely and readily available. I mean, it's amazing how much your family and friends are going to be a resource for you. Managed care, often considered the enemy, may in fact be a strong resource for your patients, but just remember, don't get into bed with one managed care company exclusively. I've seen a couple of practices that have gotten into serious trouble because they were aligned to just one company. But if you spread it out, this is certainly a way in which I think you can enhance the growth of your practice. Other areas, newspaper, radio, television, they love hearing from you. They want to hear from you. You're the expert. Don't be shy. And remember that the most important marketing starts when your phone is picked up. So put a message on the phone. Tell them what you do. Tell them about your studies. Tell them what you've achieved. This is, after all, why they're coming to see you. I'd like to mention one final thing, because this is where a total new revolution is coming. It's the advent of electronic medical records. I think it depends where you are in practice. As I said, being in it for 27 years, for me to suddenly change my practice to an electronic-based system is a little scary and a big investment. But I think if one is intending to be in practice for the future, you are going to have no choice. It's going to be mandated that most of our reimbursement is going to basically be dictated by the electronic quality of our practice, both in terms of record keeping, prescriptions that we write, and justification and documentation of outcomes. So there are 6 levels of technology that EMS is broken then down into, and if you look at the growth from 2002 to 2005, you actually see that this is an explosive area where new practices are all going electronic immediately. Old practices are moving into this area. And I think this is something that is just unavoidable and part of the practice. So if this is the year of EMR implementation in your practice, there's a list of companies out there that are providing this. Be very careful that you choose someone who has a track record, that has been around, that someone will vouch for, because many of these companies have come and gone, and I fear that that will happen more and more as this becomes more and more an area of great demand. So I think what I'd like to do at this point is say, I hope I've given you a small insight into what you can do with your practice. Rheumatology is a fantastic specialty. I'm sure you're all proud that you've chosen it, and I truly believe we just need to listen to our patients, and we can provide them with the kind of care that, in conjunction with these new medications, the new wonderful drugs and diagnostic tools that are coming down the pike, this is the specialty to be in. And I thank you for being here today with me, with Mark, and I hope we'll do this again. Thank you very much.